Before someone is diagnosed with dementia, something strange usually happens first. They start forgetting tiny things nobody takes seriously, until the tiny things stop being tiny. What if the real trigger isn't aging, but a medication taken every night, without fear, without warning, and without anyone realizing what it's doing to the brain over time? If you're serious about taking better care of your health, make sure you subscribe. I share simple, practical advice designed especially for seniors. And feel free to leave a comment telling me where you're watching from. I appreciate every one of you. Let's get back to it. I want you to try something right now. Think about the last time someone you love forgot something they should have remembered. Not a small thing. Something that made you pause. A name, a date, a conversation you'd had just days before. And you smiled. You moved on. You told yourself that's just getting older. But here's the question nobody asks out loud. What if it isn't? What if some of the memory changes appearing after 60 aren't simply the brain aging, but are being quietly accelerated by medications that millions of people take every single day? Medications sitting in medicine cabinets right now, trusted completely, questioned almost never. That is not a theory. That is an active area of scientific concern. And yet, most people will never hear about it at a routine checkup. Because when people think about dementia, they think genetics, they think Alzheimer's, they think family history written in someone else's DNA, something inherited, something inevitable, something beyond control. What they don't think about is the pill organizer on the kitchen counter. But here's what the research keeps finding. Medications prescribed every day for sleep problems, anxiety, bladder issues, depression, allergies, and acid reflux have appeared repeatedly in scientific studies examining accelerated cognitive decline in older adults. Not because these medications are poorly made, not because the doctors prescribing them are careless, but because the aging brain operates on a different chemical threshold, and that threshold is almost never part of the conversation when a prescription gets written. Here's the biology behind why. Your brain runs on a neurotransmitter called acetylcholine, the chemical responsible for forming memories, sustaining attention, and processing information efficiently. After 60, your brain naturally produces less of it. The reserve shrinks. And when medications that further block or suppress that system are added on top of an already reduced reserve, day after day, month after month, year after year, some researchers believe this is where the silent damage begins. A landmark study published in JAMA Internal Medicine found that higher cumulative exposure to anticholinergic medications, drugs that block the acetylcholine system, was significantly associated with increased dementia risk in older adults. Not temporary brain fog, not simple drowsiness, dementia risk. And here's what makes this even harder to catch. Most seniors are not taking one medication, they're taking several. And when multiple medications begin overlapping each one, adding a small cognitive burden, the combined effect can look exactly like early dementia. The forgetfulness, the confusion, the personality shifts, and families assume naturally that time is the cause. Today, we are going through 9 medications that research has flagged for cognitive risk after 60. We start with medication number 1, one of the most widely used drugs in the world, sitting in homes everywhere, trusted without a second thought. But stay with me until the very end. Because the 9th medication on this list is the one absolutely nobody expects to find here. It isn't what you think, and it may be the most dangerous pattern affecting the aging brain today. Let's begin. Let's start with something sitting in millions of bedrooms right now. Not behind a pharmacy counter, not requiring a special prescription, right there on the nightstand, next to a glass of water, taken without a second thought before the lights go out. Over-the-counter sleep aids, specifically the ones containing an ingredient called diphenhydramine, the active drug inside some of the most recognized nighttime products on the market. Names people have trusted for decades. Medications that feel so routine, so harmless, so ordinary, that most people never once think to mention them during a doctor's visit. And that silence is exactly where the problem hides. Here's how this starts. A person has trouble sleeping. Maybe it's stress. Maybe it's a life change. Maybe it's just the restlessness that comes with age. So they pick up a box from the pharmacy shelf, something marketed with words like nighttime relief and gentle sleep support, and they take it. It works. So they take it again the next night. And the night after that? Weeks pass, then months, then years. And what started as occasional help becomes a nightly ritual nobody questions anymore. But here is what the label never tells you. Diphenhydramine is an anticholinergic drug. That means it works by blocking the acetylcholine system, the exact same neurotransmitter system we just discussed. the one responsible for memory formation, attention, and cognitive processing, the one that already naturally declines after 60. Every night this medication is taken, it suppresses that system further. And in a brain that already has a reduced acetylcholine reserve, that suppression doesn't simply wear off with sleep. Research suggests the effects can accumulate. A study published in JAMA Internal Medicine, one of the most referenced investigations into this topic, found that higher cumulative anticholinergic drug exposure was significantly associated with increased dementia risk in older adults. Diphenhydramine carries one of the stronger anticholinergic ratings on clinical burden scales used by researchers and pharmacists. Translation: the drug millions of seniors take to rest their brain at night may actually be burdening it over time. And the symptoms don't announce themselves dramatically. There's no sudden warning. Instead, mornings feel a little foggier than they used to. Focus takes longer to arrive. Words that used to come easily now require reaching. Reaction time slows almost imperceptibly. And slowly, so slowly that nobody connects it to the small white pill taken every night, the brain begins operating below its potential. What makes this especially difficult is the trust people place in anything sold without a prescription. If it were dangerous, they think, it wouldn't be on a regular store shelf. But the danger isn't in a single dose. It's in the quiet accumulation of hundreds of doses across months and years inside a brain that was never designed to handle that kind of repeated chemical interference at this stage of life. If you or someone you love takes a nighttime sleep aid regularly, and especially if you've noticed any changes in memory or mental sharpness, this is a conversation worth having with a doctor. Because the next medication on this list is one that people don't take for sleep. They take it to feel calm, and the cognitive cost it carries may be even harder to detect. Now we move to a category of medication that almost nobody associates with memory loss. Because when people think about anxiety pills, they think about relief. They think about the moment the chest loosens, the moment the racing thoughts slow down, the moment a person who has been wound tight for weeks finally feels like they can breathe again. And that relief is real. Nobody should dismiss what these medications do for people in genuine psychological distress. But there is a side of this conversation that rarely makes it into the room when a prescription gets written. A side that becomes critically important the longer these medications are used and the older the person taking them gets. We are talking about benzodiazepines, Xanax, Valium, Ativan, Klonopin, medications that have been prescribed for decades to manage anxiety, panic disorders, and insomnia. Medications that work sometimes remarkably well in the short term. Here is how most people end up on them long term. Something hard happens, a loss, a health scare, a period of overwhelming stress that the nervous system simply cannot process alone. A doctor, trying to help, prescribes something to take the edge off temporarily. The patient takes it. The anxiety retreats. Life becomes manageable again. But temporary has a way of becoming permanent when nothing replaces it. Months pass. The prescription gets renewed, then renewed again. And eventually, stopping feels more frightening than continuing, because by that point, the brain has chemically reorganized itself around the drug's presence. That reorganization is where the cognitive danger lives. Here is what benzodiazepines actually do inside the brain. They work by amplifying the activity of GABA, a neurotransmitter that slows neural firing and produces a calming effect. In the short term, this is the mechanism that makes anxiety retreat. But in the long term, chronic GABA overactivation creates a different problem. The brain begins to slow down in ways that extend far beyond anxiety relief. Memory, encoding the process by which new experiences get converted into retrievable memories, becomes less efficient. Processing speed decreases. Neuroplasticity, the brain's ability to form new connections and adapt, begins to diminish under prolonged chemical sedation. And in older adults, where the brain is already operating with reduced neurological reserve, these effects can be significantly more pronounced. The research here is difficult to ignore. Multiple large observational studies have linked long-term benzodiazepine use with increased risk of cognitive impairment and dementia in adults over 60. One widely cited meta-analysis found that benzodiazepine users had a significantly higher risk of developing dementia compared to non-users, with risk appearing to increase alongside duration of use. But here's what makes this especially heartbreaking in practice. The cognitive symptoms caused by long-term benzodiazepine use the mental slowing, the memory gaps, the emotional blunting, the difficulty concentrating look almost identical to the early stages of dementia. So families watch the decline. Doctors observe the symptoms. And sometimes, the conclusion reached is that the brain is simply deteriorating with age, when the actual contributing factor is right there, in the prescription history. That possibility that what looks like irreversible decline may have a chemical explanation is exactly why medication reviews matter so profoundly. After 60, now, if the last two medications surprised you, the next one will stop you completely. Because this one isn't prescribed for the brain at all. It's prescribed for something far more physical, something most people consider completely unrelated to memory. And yet, it carries one of the strongest anticholinergic ratings of any medication on this entire list. The connection is not obvious, which is precisely why almost nobody sees it coming. Nobody talks about bladder problems comfortably. That's just the reality. It's one of those quiet struggles that millions of adults over 60 deal with privately. The urgent trips to the bathroom, the interrupted sleep, the social anxiety of being too far from an exit. It affects confidence, it affects independence, it affects quality of life in ways that are deeply personal and rarely discussed openly. So, when a doctor offers a solution, a medication that reduces urgency, restores control, and gives people their freedom back, most patients accept it with relief and gratitude. They are almost never told what it may be doing to their brain. The medications we are talking about here are bladder anticholinergics. Drugs like oxybutynin, one of the most commonly prescribed treatments for overactive bladder in older adults. And the mechanism that makes them effective for the bladder is the exact same mechanism that makes them dangerous for the aging brain. Here is why. Oxybutynin works by blocking muscarinic receptors, a specific type of acetylcholine receptor in the bladder wall. By suppressing that signal, the bladder muscle relaxes, urgency decreases, and control is restored. It works. The problem is that oxybutynin does not stay in the bladder. It crosses the blood-brain barrier, the protective filter that separates the bloodstream from the brain, and once inside, it blocks those same acetylcholine receptors in brain tissue, including in the hippocampus. The hippocampus is the brain's memory center, the structure most critically involved in forming new memories and spatial navigation, the exact region that deteriorates most visibly in Alzheimer's disease. When acetylcholine receptors in the hippocampus are repeatedly blocked by a medication taken daily for bladder control, the downstream effects on memory and cognition can be significant. Research published in the British Medical Journal identified strong anticholinergic medications, including bladder drugs like oxybutynin, as being associated with increased dementia risk with prolonged use in older adults. And crucially, oxybutynin carries one of the highest anticholinergic burden ratings of any commonly prescribed medication. But here is what makes this situation particularly difficult. Most patients are never warned. The conversation at the prescribing appointment focuses entirely on the bladder, on symptom relief, on quality of life improvement. The cognitive risk attached to long-term use rarely enters the room, so people take it daily, for years, sometimes for a decade or more. And meanwhile, the memory slips quietly. The mental sharpness dulls gradually. And because the decline happens slowly, and because bladder problems are so strongly associated with aging anyway, nobody connects the two. Not the patient, not always the family, sometimes not even the doctor. If someone you love is taking a bladder medication, and you have noticed changes in their memory or mental clarity, that combination deserves a direct conversation with their physician. Because the next medication on this list carries a similar hidden cost. Except this one isn't prescribed for the body. It's prescribed for the heart, the emotional one. There is something deeply human about this next medication category. Because the people who end up on these drugs are not weak. They are not dramatic. They are not overreacting to life. They are people who went through something genuinely hard. A spouse lost after decades of marriage, a diagnosis that rearranged everything, children grown and gone, a body that stopped cooperating, a life that looked nothing like what was planned. Depression after 60 is real. It is common. And it deserves treatment. But the specific medications we need to discuss here, a class of older antidepressants that remain widely prescribed today, carry a neurological cost that most patients are never warned about. A cost that compounds quietly across months and years until the symptoms it creates become almost impossible to separate from the aging process itself. We are talking about tricyclic antidepressants and certain older generation drugs, amitriptyline, nortriptyline, and in the broader conversation paroxetine, a commonly prescribed antidepressant that carries a notably high anticholinergic burden compared to newer alternatives. Here is the critical issue. These medications don't just regulate mood. They carry strong anticholinergic activity, meaning they block the acetylcholine system with significant force. And by now, you understand exactly what that means for a brain over 60 operating with a naturally reduced neurotransmitter reserve. The acetylcholine system gets suppressed further. Memory encoding slows. Processing speed decreases. Mental sharpness dulls in ways that feel frustratingly familiar because they mirror almost perfectly what depression itself feels like. And that overlap is where the danger becomes nearly invisible. A senior on a long-term antidepressant begins experiencing increased forgetfulness, slower thinking, difficulty concentrating, low mental energy. The assumption made by the patient, the family, and sometimes the physician is that the depression is worsening, or that age is progressing, or that this is simply the new normal. What rarely gets asked is whether the medication meant to help the mind is simultaneously burdening it. The American Geriatric Society's Beers criteria, a clinical guideline specifically designed to identify medications that carry elevated risk in older adults, explicitly flags several of these antidepressants as medications to avoid or use with extreme caution in patients over 65, not because they don't work for mood, but because the anticholinergic load they carry creates cognitive risks that outweigh their benefits when safer alternatives exist. And safer alternatives do exist. Newer antidepressants carry far lower anticholinergic burdens. The clinical landscape has evolved. Yet, many older adults remain on medications that were prescribed years, sometimes decades ago, during a vulnerable emotional season and never reassessed. A temporary prescription that became permanent. A medication review that never happened. And a brain quietly paying a price that nobody calculated. Here is what makes this category especially important to understand. The cognitive symptoms created by high anticholinergic antidepressants in older adults can be mistaken for early dementia with alarming ease. Forgetfulness, word-finding difficulty, mental fatigue, emotional blunting, withdrawal from social life. Families grieve what they believe is irreversible deterioration, when sometimes, not always, but sometimes, the deterioration has a chemical contributor that a medication review could identify. That possibility is not small. That possibility is everything. If you are watching this and you have a parent, a partner, or someone you love on a long-term antidepressant that was never reassessed, please advocate for a medication review. Not to remove what helps them emotionally, but to ensure their brain is not silently paying a price nobody told them about, because the next two medications on this list are ones almost everyone trusts completely. Not for anxiety, not for sleep, not for mood, for the stomach, and for the heart. And the cognitive connection to both will genuinely surprise you. This is where most people stop believing the list. Because the two medications we are covering right now are not psychiatric drugs, they are not sedatives, they are not chemicals designed to alter mood or calm the nervous system. They are medications people associate with physical health, practical health. The kind of medications that feel responsible to take because a doctor recommended them, because the body needed them, because skipping them felt like a risk nobody wanted to take. One is for the stomach. One is for the heart. And yet both have appeared in scientific discussions about cognitive risk in older adults with a consistency that deserves far more public attention than they currently receive. Let's start with the stomach. Proton pump inhibitors. Medications like omeprazole and esomeprazole are among the most widely prescribed drugs on the planet. They reduce stomach acid. They treat heartburn, acid reflux, and ulcer-related conditions. They work effectively, and they are taken so casually that many people consider them barely different from a daily vitamin. But long-term use of proton pump inhibitors has been linked in multiple observational studies to an increased risk of cognitive decline and dementia in older adults. The mechanism researchers point to most frequently involves vitamin B12. Stomach acid is essential for absorbing B12 from food. When acid production is suppressed long-term, B12 absorption can decline significantly. And vitamin B12 is not optional for brain health. It is critical for maintaining the myelin sheath that protects nerve fibers and supports efficient neurological communication. A brain chronically low in B12 does not fire efficiently. Memory suffers, processing slows, and the deficit builds so gradually that by the time it becomes clinically obvious, years of quiet neurological cost have already accumulated. Now the cholesterol connection. Certain statins, particularly lipophilic statins, meaning fat-soluble versions that can cross the blood-brain barrier, have been examined in research for their possible effects on cognition in some individuals. Cholesterol is not simply a cardiovascular villain. The brain is roughly 60% fat, and cholesterol plays a direct structural role in building and maintaining synapses, the connection points between brain cells, as well as supporting myelin production. When cholesterol-lowering medications cross into the brain, some researchers have raised questions about whether they interfere with these structural processes in certain vulnerable individuals. This is not an argument against statins. Statins save lives. They reduce heart attack and stroke risk with documented, significant evidence. The point is not avoidance. The point is awareness. Monitoring for cognitive symptoms in older adults on long-term lipophilic statins and discussing those symptoms openly with a physician, rather than dismissing them as age, is a conversation that more families need to be having. Because the medications people trust most are almost always the ones least questioned. And trusting without monitoring is exactly how silent damage goes undetected for years. What comes next goes somewhere darker. Because the next two medications are not taken at home. They are administered inside care facilities. And the story behind them is one that every family with an aging loved one needs to hear. What I am about to share is not comfortable, but it is necessary. Because this next part is not about medications people choose for themselves. It is not about a prescription filled at a local pharmacy or a pill taken quietly before bed at home. This is about what sometimes happens when families can no longer manage alone, when the burden of caregiving becomes too heavy. When a loved one moves into a nursing home or an assisted living facility, and the family trusts that the system will protect them, sometimes it does. But sometimes, the very medications administered inside those facilities become part of the problem nobody sees. We are talking about antipsychotics prescribed to elderly patients. Drugs like haloperidol, quetiapine, and risperidone, administered to manage agitation, wandering, aggression, and sleeplessness in older adults. The FDA has issued formal black box warnings, the strongest safety alert the agency issues, stating that antipsychotics used in elderly dementia patients carry significantly increased risks of stroke, cardiovascular events, and death. Beyond mortality risk, the cognitive cost is severe. Antipsychotics suppress dopamine pathways. In older adults, that suppression doesn't just calm behavioral symptoms, it can strip away executive function, emotional expression, and the remnants of personality that families are desperately trying to preserve. Families visit and notice something missing, not just calmer, absent. This is where the second part of this conversation becomes critical. Because antipsychotics rarely arrive alone, they arrive alongside sleep medications, bladder drugs, antidepressants, and antihistamines, each individually justified, collectively devastating. If you have a loved one inside a care facility right now, ask for a complete medication list. Ask what each drug is for. Ask when it was last reviewed. Because sometimes the people we place in systems designed to protect them need us to keep watching anyway. What comes next goes somewhere darker. And it may be the most important thing you hear in this entire video. We have spent this entire video talking about individual medications. Sleep aids, anxiety pills, bladder drugs, antidepressants, heartburn medications, cholesterol drugs, antipsychotics, each one carrying its own risk. Each one documented in research, each one worth a serious conversation with a physician. But here is the truth I have been building toward since the very first chapter. The ninth and most dangerous entry on this list is not a single medication at all. It is what happens when multiple medications combine inside one aging body, silently stacking, quietly accumulating, building a chemical burden that no single prescription was ever designed to carry alone. It is called anticholinergic burden. And it may be the most underdiagnosed contributor to cognitive decline in older adults today. Here is how to understand it. Researchers have developed clinical tools called anticholinergic burden scales, scoring systems that assign each medication a rating based on how strongly it blocks the acetylcholine system. A low-rated drug scores 1 point, a moderate drug scores 2, a strong anticholinergic scores 3. Now imagine a person taking a sleep aid, a bladder medication, an older antidepressant, an antihistamine for allergies. Individually, each prescription has a clinical justification, but add those scores together, and that person is carrying a cumulative anticholinergic burden that research has directly linked to measurable cognitive impairment, memory loss, processing decline, and increased dementia risk in older adults. A landmark study examining thousands of elderly patients found that those with high cumulative anticholinergic burden scores showed significantly greater rates of cognitive decline compared to those with lower scores. Not marginally greater, significantly greater. And the truly devastating part of this finding, the decline those patients experienced was frequently attributed to aging, to inevitable deterioration, to a diagnosis of dementia that arrived with grief and finality when the actual driving force was a medication combination that nobody had ever stepped back far enough to evaluate as a whole. Because here is the painful reality of modern medicine for older adults. A cardiologist manages the heart medications. A urologist manages the bladder medication. A psychiatrist manages the antidepressant. A general practitioner manages everything else. And nobody is looking at the complete picture simultaneously. Nobody is calculating the total neurological cost of everything combined. That gap, that dangerous space between specialties, is where anticholinergic burden grows invisible and unchallenged for years. But here is what I need you to hold on to before this video ends. Drug-induced cognitive impairment is sometimes reversible. Not always, but sometimes, when identified early enough, when medications are reviewed carefully, when a physician who understands anticholinergic burden gets involved, cognitive function can improve. Memory that families believed was gone has returned. Clarity that seemed permanently lost has re-emerged. That possibility deserves to be fought for. So here is your action plan. Write down every medication being taken, prescriptions and over-the-counter products, both. Bring that complete list to a physician and ask specifically about anticholinergic burden. Request a full medication review. Ask whether any drugs can be substituted for lower burden alternatives. And if your concern is dismissed, without genuine evaluation, seek a second opinion. Because memory is not just recall. Memory is identity. Memory is the thread connecting every relationship, every experience, and every version of a person across an entire lifetime. And protecting it is worth every difficult conversation. The scariest memory loss is not always the kind caused by disease. Sometimes, it is the kind that nobody saw coming, until now. Thanks for watching all the way through. Staying informed is key to living a healthier, longer life. If you want more simple, practical health advice, make sure you subscribe and tap the next video on your screen. And before you go, leave a comment and rate this from 1 to 10. Your feedback helps me create better guidance for you.